Hello, my name is David Back, and this is the first in a series of educational talks on the disposition of drugs, and then we're going to try to apply that specifically to the direct-acting antivirals, the DAAs. So this talk is entitled Basic Principles of Pharmacokinetics. So we have to look at learning objectives, and we have three specific learning objectives in this talk. Number one is to understand the basic principles of pharmacokinetics. The second is to define key pharmacokinetic parameters. And then thirdly, to appreciate that there are very different methods that we can analyze pharmacokinetic data. So let's get into the talk and ask the question, why do we want to understand pharmacokinetics? And there are a number of reasons why, for a hepatologist or for someone who is in research or someone who is in education, actually understanding pharmacokinetics is really important. Number one is to appreciate how dosing regimens are devised. Why do we give a drug once daily? Or why do we give it twice daily? Another reason is to how do we design dosing regimens to individual patients? So for example, you've got a patient who's got hepatic impairment or renal impairment. How do you devise the dose for that patient? Or a patient who's got multiple drugs in their regimen and there's a potential drug-drug interaction, which is going to be a major feature of this series of talks. Or for example, in children, do we give the same dose to children as we do to adults? Then we can determine what is wrong if a patient fails to respond to treatment. So is the drug being absorbed? Or is there a competing co-medication which is affecting the drug absorption? We can find out why a drug has caused toxicity. Sometimes we get adverse reactions to drugs. So why is that adverse reaction occurring? Is it to do with the concentration of the drug? Is it too high in the individual patient? Or is it the metabolite, a breakdown product of the drug, which is responsible for that drug problem, that toxicity? And then finally, we can elucidate mechanisms of drug-to-drug interactions. Mechanisms such as enzyme inhibition, enzyme induction, transporter inhibition, and transporter induction. So these things are important for us to consider, and we will go through this in this and subsequent talks. So basic principles of pharmacokinetics and pharmacodynamics are important for us to realize. So what is the difference between pharmacokinetics and pharmacodynamics? Kinetics is what the body is doing to the drug. Dynamics is what the drug is doing to the body. Now clearly we want the drug to bring about its effect. That's why we're giving the drug. That's the drug effect in the body. But we also have to think about the body doesn't like having drugs. It's reacting against having a foreign molecule, a foreign thing. So it's trying to do something to it. What's it trying to do? Well, initially the drug is going to be absorbed. So if you give a drug orally, the absorption of the drug can occur. And we want the drug into the bloodstream in order for the drug to get to its pharmacological site of action. And then the drug is distributed around the body. It's not just going to where you want it. It's being distributed to multiple sites within the body. And then the body tries to get rid of the drug. It metabolizes it and it excretes it in order for the way for that drug to be removed from the body. So those are important mechanisms of pharmacokinetics. Now we can go further and we can define certain key pharmacokinetic concepts. So bioavailability, how much of the drug which you take is actually available within the bloodstream? That's bioavailability. And then we have a parameter called volume of distribution. Where's the drug going? You want the drug, for example, to act in the CNS system, in the brain, but where else is it going in the body? And you can try to think about the volume, the distribution of that drug throughout the body. And then the clearance of the drug, the removal of the drug by the processes of metabolism and excretion. So these are all important concepts that we have to define and think about in understanding basic principles. So bioavailability, sometimes for a bizarre reason, it's given the letter F. Probably that's fractional bioavailability, the fraction of the drug which is available in the bloodstream. And so we can define it in that way. It's the fraction of the unchanged drug which has been taken which reaches the systemic circulation after administration. And then clearance. What is clearance? Well, clearance is the volume of the blood, the plasma from which the drug is being removed over time. So the body is getting rid of the drug, and it's the volume of the blood from which we're getting the drug removed. And then volume of distribution, that's a parameter actually which is apparent. It's the apparent volume into which the drug is going, and has different values for different drugs. So these are some of the key concepts, parameters that we have to define. So let's think of this in a more pictorial way. So the red disc at the top is the drug. So let's think of that as being the tablet. You give the tablet, it's 100% drug. And the tablet goes into the stomach. So again, you've got 100% of the drug in the stomach. But as it goes through the stomach, some of that drug might be broken down. And you have to get the drug in a form from the tablet where it can be absorbed. Now, not all of that drug may be absorbed. So you can get drug lost as it passes through the intestine. It may be because the drug is not absorbed. Or it may be that the drug is actually metabolized in the intestine. So not all the drug that is taken as a tablet may actually get to where you want it. And then when the drug is being absorbed from the intestine into the bloodstream, it has to go through the liver. So drug can be metabolized in the liver. So what drug actually gets into the general systemic circulation may only be a fraction of what is being taken in that tablet which the patient is taking. So we have to think about what bioavailability is. So let's just consider an example which might help us go through stage by stage. Let's assume the drug is not all absorbed. In fact, 40% is not absorbed, we'll assume, which means that only 60% of the dose, or the fraction of the dose, 0.6, is actually absorbed. Then as it's absorbed, it hits the liver on the first time. When it hits the liver, some of the drug may be metabolized. Let's say 50% of what the liver is seeing is immediately broken down. So the bioavailability is only going to be 30%. That is 0.6 times 0.5, 0.3, which is 30% of the drug. So 70% of what you actually took in the tablet doesn't get into the systemic circulation. That's just maybe that's an extreme example, but it's just illustrating what the concept of bioavailability and loss of drug is. Let's think about what happens when you give a drug. Oral administration is the most common way. And this diagram is showing the plasma concentration, the blood concentration versus time. And as the drug is absorbed, so you arrive at a peak concentration of the drug. We call that the Cmax, the concentration at the maximum. So that's the maximum concentration of the drug, which will occur at a time which is given as Tmax. That's the maximum time to give you that Cmax, the maximum concentration. And then we can have a parameter called the area under the curve. That's the total amount of drug in the time interval which the patient is actually seeing. How much drug is in the patient? This parameter, area under the curve, is very helpful to describe that. And then we can look at the rate at which the drug is being removed, termed the elimination half-life. And that's a really important parameter. How quickly is the drug being removed from the bloodstream? Or how long is the drug staying in the bloodstream? And then finally, the parameter which is important for us to think about is the clearance of the drug, the oral clearance, which is related to the dose which is taken, the bioavailability, how much drug is it getting into the systemic circulation, and that parameter of the area under the curve. So these are concepts, parameters, which we'll come across as we go through this series of talks. So how do we find half-life? Well, half-life is clearly the time taken for half the drug to be removed. Now, I've shown on this diagram the linear aspect of removal of the drug. And to get a linear aspect, you sometimes have to get the logarithmic. So it's rather than just the profile which we saw in the previous diagram, we've got the log of the concentration versus time, because that gives us a line which we can determine the half-life much more easily. And you can see here that you start with the concentration declines by half in the bloodstream, that is the half-life. Declines again by half, you've got a second half-life, etc. Actually, the half-life is the same, but you've got these different half-lives. And the time to eliminate the drug will be around 5 half-lives at the most. So that gives us an idea. If you've got a half-life of a drug of 6 hours, then in 4 or 5 half-lives, 24 to 30 hours, all the drug will be got rid of from the body as far as this concept is concerned. But we tend not to give drugs just as single doses. So someone normally takes a course of drugs and they take it once a day or twice a day for a week or a month, or even every day for life. So if you're on an antihypertensive, for example, then you are likely to be on that drug for life, or a statin, you may be on it for life. So we give the drugs once daily. So here we're looking at blood concentration of the drug over the 24-hour periods, and we're looking at this daily administration of the drug. And once you start to take a drug, the concentration builds up until you get what is termed a steady state concentration. And that steady state concentration is when the drug loss per 24 hours actually equals the drug intake per 24 hours. And then you've arrived at a steady concentration. You've got a steady Cmax and a steady trough concentration of the drug. And the time to get to that steady state is around the 4 to 5 half-lives again. So just remember this 4 to 5 half-lives for elimination, and also to arrive at the steady state of the drug. So how do we get this sort of information? Well, we do pharmacokinetic trials. So in drug development, very important that you do a pharmacokinetic trial to understand all of these parameters for your new drug. When a drug has been licensed, post-licensing, we will do these pharmacokinetic trials so that you can use healthy volunteers or patients, and you get pharmacokinetic sampling or blood sampling in order to be able to understand how much drug is in the bloodstream. It can be intensive sampling over 24 hours or longer, or it can be sparse sampling, just taking maybe one drug, one sample every day over a period of time. You then quantify the drug, take it to the laboratory, you quantify by bioanalysis, and then you can work out these pharmacokinetic parameters that we've been discussing. And then, of course, you have to interpret the data. What does it all mean? You've got these blood samples where you've got drug levels, and now you interpret the data in order to understand your drug in the patient, in your volunteer, and the implications of that. So there are two principal methods to analyze pharmacokinetic data. The first is termed non-compartmental analysis, or NCA. And this is used where we want to determine the degree of the exposure of the drug in the bloodstream, and then to determine those parameters which we discussed earlier, such as clearance and half-life and Cmax. This is the most often used method of analysis, but there are other methods as well. So for example, there's the method which is termed model fitting by nonlinear regression. And here we're making certain assumptions, and we're trying to maybe more understand the disposition of a drug in a bigger population. This is termed population PK analysis. So we're looking at population data and understanding different covariates that can affect the drug exposure in that population. It's a top-down approach, so that we're using data, and then we're using the variables which are in a population to see how they can affect the drug concentration. Just finally note that there is another method which is called physiologically based pharmacokinetic modeling, which is a bottom-up approach. It's not using data derived from the patient. It's using data which we derive from the laboratory, and then the physiological parameters which we know that are in patients, and then we can derive the parameters by another modeling approach. So just bear in mind that there are different approaches. So finally, just to summarize, the understanding of pharmacokinetic principles is really important, and I hope I've conveyed that across in this talk, that if we're going to use drugs safely and effectively, then understanding some of these parameters can really help us in the management of individual patients.